Well, hello everyone. Welcome to today's webinar on hot topics in healthcare infection prevention and control. Today's webinar is the product of a partnership between the Ohio chapter of the American Academy of Pediatrics, the Ohio Department of Health Bureau of Infectious Diseases, Healthcare Associated Infections Antimicrobial Resistance Program, and the CDC's Project First Line. We're so excited to have you all here today and to have a great conversation, I think, around current issues in infection prevention and control. Next slide, please. Thank you. So for those claiming CME today, our objectives are to learn how to address vaccine hesitancy amongst healthcare workers, to utilize protective or personal protective equipment in the primary care setting, to describe preventive care for international travel, and finally, we'll think about where primary care and school health intersect and how we can collaborate around shared best practices. Next slide, please. And for those claiming CNEs today, our objectives are the same, with the outcome that you will have increased knowledge regarding healthcare infection prevention and control. Next slide, please. So I mentioned Project First Line a moment ago, and we may not all be familiar with the program. So I'll just do a little brief intro. Project First Line is the CDC's educational collaborative for all types of healthcare workers to learn about and have access to resources around infection prevention and control. So these resources utilize easy to digest formats and adult learning principles to try to empower healthcare workers with evidence-based best practices coming from the CDC. So if you'd like to learn more, you can access their website from the link on the slide when we share the deck after today's discussion. Next slide, please. None of our participants in this program have any disclosures to share. Next slide. And as we prepared for today's conversation, we were mindful that the CDC defines health equity as the state in which everyone has a fair and just opportunity to attain their highest level of health. Next slide, please. So my name is Rupa Thakur. I am a primary care pediatrician at the Cleveland Clinic. I attended Ohio State University, for medical school and completed my pediatric residency training at Cleveland Clinic prior to joining as staff. So my current roles there include medical director for school-based healthcare and medical director for youth strategies in Cleveland Clinic's community health equity team. I'm also honored to moderate today's webinar and excited to hear what questions you may have as we hear from our panelists. So with that, I'll ask our first speaker, Dr. Nicole Kaiser, to introduce herself.
Hi, everyone. I'm Dr. Nicole Kaiser. I am a general pediatrician with UH Children's Medical Group. I attended medical school at Northeast Ohio Medical University, and then I did my residency at Akron Children's Hospital. Upon completion from residency, I joined UH Rainbow, initially at Rainbow Portage Pediatrics, and then a year ago, I moved to my current location at Children's Medical Group in Hudson and Fairlawn. Next slide, please. We're going to move through a couple of different sections here. This slide just illustrates the different components that we're going to address. The first, we're going to discuss learning how to address vaccine hesitancy, and more specifically amongst healthcare workers ourselves. Next slide, please. So when we approach the subject, it's important to reflect on why we vaccinate. We vaccinate to prevent the disease itself, as well as the morbidity and mortality that might come with it, as well as the sequela that might come after it as well. The most important thing we can do is to prevent when regards to infection control. If we're unable to prevent the disease from occurring, then our next two best options are standard precautions and transmission-based precautions. In this portion, we're going to discuss more from a prevention aspect of vaccines, and then subsequently we'll move into, in a different section, we'll talk about standard-based and transmission-based precautions as well. Next slide, please. Vaccine hesitancy. Common sentiments I hear: the vaccine will make me sick. It's better to have had the disease than to receive the vaccine. I've already had the flu. I don't need my flu shot. The vaccine will cause the disease. Next slide, please. When in reality, vaccines are, in fact, they're effective. They're so effective that one dose of MMR is about 93% effective against preventing measles, 78% effective against preventing mumps, and about 97% effective against rubella. And then the second dose can increase that up even further. Vaccines strengthen your body's natural immune defenses. Getting vaccinated is safer than contracting the disease. In fact, now with the introduction of the HPV vaccine, we have a vaccine that can actually prevent cancer. Unfortunately, most of us probably have firsthand knowledge of either for ourselves or a loved one of experiencing cancer and how unpredictable that course can be, and even side effects from the medication whenever we have a vaccine that can prevent it from even happening in the first place. Vaccines often do cause mild side effects. The most common tends to be pain at the injection site, redness, swelling, sometimes a little low-grade fever, fatigue, malaise. Vaccines are also continuing to be monitored for safety and efficacy. I get a lot of questions about this in my practice, about when did it come out? What do we know about it? What are we continuing to look for? The VAERS is a vaccine adverse event reporting system, and they continuously accept reports of vaccine safety. Anyone can report, whether a healthcare provider or even a patient as well. Next slide, please. So sometimes with vaccines, we're met with resistance, and this was fueled even more so by the COVID-19 pandemic, as it was more of a fluid state at the time. So mistrust that we often hear about, mistrust about what are the ingredients? Are they safe to go in my body or my child's body? Mistrust about what is the vaccine actually preventing? A lot of people have never experienced anyone that's had measles, thankfully, but they don't understand, is it a real threat or not to them and their family as well. I've had some families with mistrust regarding, we're saying that we're vaccinating against influenza. Well, how do I know that they didn't sneak the COVID vaccine in there somehow? Uncertainty about what is my true risk. If I don't get this vaccine, will I truly end up with the disease? Or is my child going to be at increased risk? And what about possible side effects? Politicization, again, fueled again since the COVID pandemic as well. And then lack of adequate information. We live in a society that often goes to social media for guidance. They're receiving information from sources that aren't credible, yet they're a lot of times willing to believe them over healthcare professionals with valid information to offer. In reality, vaccines are among the greatest public health achievements of modern times. They've saved millions of lives throughout the world, and most patients and healthcare workers don't have firsthand experience of a lot of these devastating consequences of many of the disease we prevent because vaccines have been so successful. Unfortunately, due to vaccine refusal, we're starting to see some of these outbreaks of the communicable diseases, so such as measles. Before the measles vaccine was introduced, between about 400 to 500 people died in the US every year. Next slide, please. So if we know vaccines are so important and so successful, what can we do to try to increase these rates back up to what they were? Some thoughts would be having vaccine ambassadors. And these more specifically are talking again amongst us as healthcare providers in our offices, in our hospitals. Who can we try to help kind of bolster the discussion about vaccines as well? So trusted individuals here. And again, providing resources to back that up. So referring to the CDC guidelines or the AAP guidelines as well. Medical provider vaccine standardization. So over the past few years, I've had the opportunity to work at a variety of different offices. And between the different offices, they will have slightly different schedules, which can sometimes throw off parents if they're expecting one vaccine and the provider is providing a different vaccine. So trying to make sure that we're all following the same guidelines as well, so that parents come to know and expect what they can be receiving at that visit. Ensuring to send reminders about when vaccines are due. During adolescence, a lot of times we'll have gaps in care as they are having more time in between vaccines that might be mandated from the school. Usually when children are smaller, less than 2, we see these children very often, very frequently. So we have the opportunity to have these conversations quite frequently and help provide that relationship. But during adolescence, we tend to kind of stray a little bit more. So trying to make sure to remind everyone how important it is and to send out those reminders too when it comes to flu season, whether it's through an email, a text, or phone call reminders, especially reminding to come back in the fall. So their well visits could be a different time of year. So reminding them, make sure we come back in the fall to get our flu shot or to get our COVID shot too. And then two, from a healthcare provider work environment standpoint, reminding everyone to, get their flu shot. And I'm sure most healthcare facilities do a pretty good job of that, but just understanding the importance of trying to first and foremost prevent anything from happening. Financial incentives, they were some success with the strategy during the COVID-19 pandemic. And then having workplace vaccine programs where you don't have to leave during working hours, that someone comes to you or comes around the hospital, or you meet at a certain location during your set working hours, and making sure too to cover different shifts as well. Some of those later day shifts might be more challenging, but trying to make sure that everyone has access and equal opportunity to those as well. And then providing effective messages delivered by trusted messengers too. So ensuring that the message that we're trying to convey is accurate, that it's concise, providing resources to back it up, and then combating misinformation. This can be tiring to constantly feel like we're fighting against the current, but keeping in mind that what we're doing isn't in vain, that we're trying to prevent unnecessary morbidity and mortality, and even unnecessarily burden on strain on our healthcare infrastructure. I'm sure most of us were impacted by the COVID-19 pandemic and everything that followed from that. So just trying to figure out best practices to try to minimize where we might get overburdened by some of the diseases that we can in fact prevent. Next slide, please. Next slide, please.
So we'll take a moment here. If there are questions from the audience, I would love for you to pop them into the chat and we can ask them of our experts as we go. But I was just wondering, previously, I used to hear a lot of resistance from my patients. So not healthcare workers, but from my patients around, my child has an egg allergy, and so I don't want to get them vaccinated. And I wondered if this is something that still comes up, or if there's anything that, healthcare workers might still be using this as a reason not to vaccinate when we know that that's no longer a contraindication. I was just curious about your thoughts on that.
So I think alleviating their fears when it comes to egg allergy, that anyone with an egg allergy can in fact receive their influenza vaccine and other vaccines as well, that the protein is different, even though, so that they are safe, even if they do have an egg allergy.
A lot of re-education, as you mentioned. Okay.
And that's important, again, re-education and making sure it's consistent and concise, that we're not saying that providers aren't saying different things.
Okay. As I said, please continue to pop your questions into the chat. For now, we'll move on into the next section of our content around utilization of PPE in the primary care setting. And since we have some school health representation here, I will present what I hope is a realistic case to illustrate how a sick school-age child might present. So let's say we have a 6-year-old female whose parents have opted out of vaccinating after 9 months of age when her older brother was diagnosed with autism. It's March, so still cold and flu season, and she presents to the school nurse's office with a fever. At this point, what PPE do you think the school nurse would don prior to evaluating the child? Or, what would typical PPE be in this situation? Hand hygiene alone, face mask, gloves and gown, or gloves, gown, and a particulate respirator. Go ahead and pop your answer into the poll question here. Will I be able to see the responses, Olivia?
Yes, if we're ready to close it, I can end the poll and share if we're ready.
We have 23 participants, several of them from our team, but yeah, whenever you feel like you're ready,
Okay.
that's fine.
It's been about a minute, so I'll go ahead and pause or end the poll.
Okay, so it seems like we're mostly split between hand hygiene and face mask, with a few folks opting for gloves and gown, and then also a particulate respirator. So, okay, we have a sense of kind of what a school nurse might go into this situation with. If we could hit next, please. All right, so the very busy school nurse with 2 other kiddos in the office evaluates the child who's found to have a temperature of 103, cough, runny nose, and pink eye. So she gives the child a dose of ibuprofen for the fever and calls the family, refers them to see their PCP, or in this case, an on-site school-based health provider. So based on the constellation of symptoms that we now have, the school-based health provider is thinking that this might be a viral URI, something like adenovirus or something similar, just based on the triage that they've gotten. So what PPE do you think this provider would typically put on prior to evaluating the child? So we have the same options here: hand hygiene, face mask, gloves and gown, or gloves, gown, and a particulate respirator. What do you think? All right, so now we have the majority are thinking maybe a face mask would be appropriate, with still a few thinking hand hygiene and maybe the gloves, gown, and particulate respirator. But largely, we're thinking a face mask would be good to use. All right, if you could hit next, please. So now the provider assesses the child. Her temperature has come down in response to the ibuprofen. And when she does the oropharyngeal exam, the provider notes some Koplik spots, which are classic for measles infection. So what do we think now? Was the appropriate PPE used from the beginning? And as we think about this, we can think about how many people were exposed to this child with measles and what the risk for further infection spread through the community based on our healthcare providers' PPE choices might have been. So what do we think? Did we use the right stuff or not? All right, so I think several of us have identified that we did not make the right PPE choices. Either both the school nurse, I would say, and the school-based health provider or PCP who saw that patient assumed that it was appropriate just to wear a face mask. And we will hear from Dr. Kaiser what our choices should have been. So I'll pass the mic back to her.
Okay, so we're going to go through a refresher on PPE and donning and doffing and the different types of precautions. So PPE, personal protective equipment, it's a very popular phase these days, but it's important to remember when it's necessary to use it and ensuring that we've had proper training, which we're going to cover a little bit later as well. Ensuring proper fit, especially with respirators such as N95 masks, and ensuring that the PPE is not damaged or defective in some way. Next slide, please. So PPE consists of many different components, such as gloves. So anytime we might be touching any blood or bodily fluids or contaminated surfaces, Gowns, anytime we think that we might have any contact with our clothing or our exposed skin to any blood or bodily fluids as well. And then mask, eye, or face shield protection whenever we're concerned that there could potentially be any splashes, sprays of any of those fluids as well. Next slide, please. So standard precautions. So standard precautions, we should be using these for all patient care. They protect healthcare providers from infection ourselves and also preventing from the spread of infection from patient to patient as well. So hand washing should occur with every single patient, no matter what, washing in, washing out of every encounter as well. Ensuring proper kind of cupping technique too, handling of equipment as well as injection practices, ensuring that there are proper containers for those that are easily accessible and easily visible as well. Next slide, please. We'll start with contact precautions. Contact precautions, these should be used anytime there is concern for possible direct or indirect exposure to the patient in their environment as well. So anytime, say that there is diarrhea or concern for an abscess, we should be using PP with gown, gloves, and of course our hand hygiene at minimum. Sometimes too, depending on the case, I'm using dedicated disposable equipment such as a stethoscope that stays in the room or if that's able to be adequately cleaned in between uses person to person as well. It's also important to remember that before exiting the room, that we need to leave the gown and the gloves in the room. Next slide, please. Droplet precautions. So these would be used for viruses such as influenza, adeno-rhino, and bacteria such as strep and pertussis. Anytime there's risk for spread by large respiratory droplets. For these, we're going to want to use a face mask in addition to our hand hygiene as well. And making sure that that face mask, again, is properly covering our face, our nose, and our mouth. Next slide, please. Airborne precautions. So these are diseases that are spread by small respiratory droplets. So these would include things like our measles, our varicella, and tuberculosis. So in this case, again, we should have been using airborne precautions. Again, it might not have been clear initially that that's what we were dealing with, but once we knew that we were dealing with measles, we need to make sure that proper airborne precautions are occurring. So that includes having gloves, gown, and a respirator, such as an N95. Next slide, please. So once we know we need to use the PPE, it's important to understand how to properly put that on and then also take it off. So when we're putting on, again, we should be washing our hands before putting on our gown, ensuring that it is fitting well. So making sure that we tie, that it's not draping in the front, that again, that it's covering our arms as well, that there aren't any gaps. After we put on our gown, then putting on our mask or our respirator if it's appropriate. And then lastly, again, goggles or face shield if needed. And then our gloves, and ensuring that we tuck our isolation gown into those gloves to make sure there's no gaps in coverage of our skin that might become infected by any contact with the patient as well. Next slide, please. When it comes to doffing, there are two different options for this. The first option is to first remove our gloves, then our goggles, gown, mask, and then return to our hand hygiene. If at any point though in time between any of those steps, we contaminate ourselves. So if we accidentally touch the outside of the glove, we need to stop and then wash our hands before moving on to removing our goggles, and vice versa with gown too. In between, anytime we think we might contaminate, make sure that we're stopping, washing our hands as well. Next slide, please. An alternative would be to remove the gown and the gloves at the same time, and then move on to the goggles, and then the mask, and then lastly, making sure we're doing our hand hygiene as well. Next slide, please. Besides following proper precautions to prevent disease and transmission to other patients and healthcare providers, we also need to be mindful. So anytime there's any soiled equipment, we need to make sure that that's being properly taken care of in a timely manner. When it comes to environmental control, cleaning highly touched surfaces frequently, the CDC has 4 components of culture of cleaning and disinfection, which include integrating environmental services into our culture because they are a very important part of our team as well. Making sure that we're selecting appropriate cleaning products, standardizing the cleaning protocols, monitoring the effectiveness and adherence to these protocols, and then providing feedback, ensuring that we're doing all those steps correctly. Ensuring that we're properly disposing of needles and sharps. Containers should be, again, in a location that's easily visible and accessible. And then patient placement. So during the COVID-19 pandemic, this is very popular to split up the waiting room into one side being sick, one side being well, or even breaking the day into morning for sick visits or well visits and vice versa as well, depending on the risk. So if there's a patient coming into the office that, say, again, the school nurse had identified and was concerned for measles and they're coming into our office, maybe that's a patient that we should have wait in their car or be the last patient of the day, just to make sure that we're minimizing any potential risk or exposure to any other patients as well. And then every member of the healthcare team, really, we have a duty to try to ensure transmission of diseases is as low as we can, trying to minimize by just doing at least the bare minimum of our standard precautions. And then again, trying to strategize based on what we know about what the patient's symptoms are. Do we need to go above and beyond? Do we need to look into other precautions, contact, droplet, airborne, and making sure that our other providers in our office are aware as well. Next slide, please.
All right, so we do have a few questions for you, Dr. Kaiser. What should someone do if their facility doesn't have access to the correct or enough PPE for what they think they're about to walk into?
Well,
are there alternatives, or go ahead.
Well, if they're not prepared, I mean, I think most at least bigger facilities these days typically have access to at least basic. I think most people are now fitted for their N95s and should have a stash it somewhere. We might not be using those as regularly on a day-to-day basis, but at least larger healthcare facilities should be aware. And I think, again, if we're sending someone to a different location where we have a specific diagnosis, where we know that they are going to need specific precautions, to making sure that we are giving them a heads up and passing along the information to make sure that they are capable of handling that patient. And if we don't have proper PPE, that might be a time to divert them somewhere else that is suitable to be able to make sure we're not putting anyone else at risk.
So there's some preparation that should go into it and some thoughtful planning. That makes sense. What's recommended for a primary care provider, either in the community or in a school-based health practice? What is recommended for them to do once it's been identified that the wrong PPE might have been used prior to understanding what was really going on with the patient?
Thing about medicine is that it's constantly evolving, patient symptoms. So when we initially come in, again, it sounds like in this case specifically too, it sounds like it was more of a common cold. So initially we may have provided the correct PPE for the information we knew at the same time. And then again, it's evolved over time. So being mindful of what we were, once we know, being mindful of what we were exposed to and monitoring symptoms as well.
Thank you. All right. As other questions come into the chat, we may circle back to you, Dr. Kaiser, but now I think we will move on. Dr. Mukundan?
Thank you. And it has been really nice to hear the other talks. So I'm Deepa Mukundan. I did my medical school training in India, and then my residency in pediatrics at the Medical College of Ohio, now the University of Toledo. I did complete my fellowship in pediatric infectious diseases and immunology at the University of Michigan. And currently I work as a pediatric infectious disease physician at the two children's hospitals in Toledo, ProMedica, eBay Children's, and Nationwide Children's Toledo. I'm a tenured professor and currently the chair of the Department of Pediatrics. Okay, next slide. So today I'll be talking about preventative care for international travel. And next slide. So as an overview, what I will be presenting here is there are three different aspects when you're thinking about traveling and healthcare and taking care of yourself. You have to think about it before travel, while you're traveling, and after travel, you may need to watch out for some symptoms if you have been exposed. Next slide. Provider, what do you do before travel when your patients reach out to you? Essentially, you need to know where they're going and their itinerary. Then the intake. At the intake, you also need to assess individual risk, and you also manage the risk by vaccines, prophylaxis, and education. It's very important to understand that these are all risk mitigation strategies and do not eliminate risk altogether. Next. So before travel, it's important to understand that a visit has to be scheduled at least 4 to 6 weeks before travel. That's the ideal situation. Sometimes we travel, the travel arrangement can be in the last minute, but usually most of us are traveling for pleasure, so these are scheduled way ahead of time. Now, the travel evaluation can either be done in the primary care physician's office or in a travel clinic. It depends on whether the primary care physician would do it. Now, essentially, before travel, you need to get information about the patient. Like I said, itinerary and the purpose of travel. Purpose of travel is extremely important because that will assess your exposure risk. So if you're traveling as a tourist versus somebody who's going there to study abroad or visiting family and friends, your risks, exposures are very different. In a travel clinic, the same thing happens. Your intake is extremely important. You should get as much information as you can, both about the patient and the itinerary. The link below provides it's a template for the patient to check off or the traveler to check off prior to evaluation. I would use it as intake sheet. Next slide, please. So the most common questions that I get related to travel is vaccines. What vaccines do I need to take? I'm going to XYZ country, and I do get a lot of these as curbsides from colleagues, but understand that this is a more involved assessment. So it does take time, and you do need to have a lot more information than just where you're going and who you are. So when it comes to vaccines, definitely the easiest thing to do is to update all your routine immunizations. And if the seasonal influenza vaccine, depending on if you're going to the Southern Hemisphere and you're traveling in the summer in the Northern Hemisphere, then you definitely need to take your influenza vaccine. They do have, in this table, you see the travel vaccines and the number of injections. Now, this is the reason why we have you come at least 4 to 6 weeks ahead of your travel. Because if there are 2 or 3 doses of a vaccine that needs to be given, that may take about 4 weeks, especially like hepatitis A or B. And also, your immune response takes at least 10 to 14 days. Hence, the last dose of vaccine that you take prior to travel should be at least 10 to 14 days prior to getting on that plane. Next slide. In addition to vaccines, you have to think about what are the concerns you have in terms of infectious diseases and exposures, and what are the preventative measures and whether you need any prophylaxis. Now, selecting what kind of food and beverage, and especially for families traveling with infants, breastfeeding and formula, and is very important. For the most part, I tell my families, eat cooked food that has not stayed outside for too long, well-cooked food, and also do not try to avoid as much as you can salads and fresh vegetables unless you know the source. In terms of fruits, if you are peeling the fruit yourself, great, you can have it like bananas and oranges, but fruits that are unpeeled may have a higher risk for contamination. Now, do we need to use any medications? Bismuth subsalicylate has been recommended for adults, but not for children for diarrhea. And probiotics, we do not have sufficient data in prevention of diarrhea. Prophylactic antibiotics are a big no. They are not recommended. However, in unusual situations in an immune compromised patient, they may be, but then you need expert advice for that. And you should also need to understand where to get treatment if you do need medical attention. Next slide. Another big area of prophylaxis is prevention of malaria. Again, as you know, it depends on where you would be going, more so in the tropics. Not only where you're going, it also depends on the resistant patterns in that area. Now, understand that just taking malaria prophylaxis doesn't prevent you from getting other diseases related to mosquito bite. And also, you're only decreasing the risk of getting malaria, but not eliminating it altogether. So you should still use avoidance measures like using protective clothing, insect repellents, and bed netting or screens when sleeping. Again, I can't how important this is, because these measures, again, decrease risk but not eliminate risk. Next slide. The education piece, till now we talked about vaccines, prophylaxis, and then education is extremely important. Frequent hand washing and sanitizing. Understand hand washing in dirty water really doesn't hold. So you do need clean water to wash your hands. If that's not available, then a sanitizer is a reasonable alternative. And other things that you need to do, wearing seat belts, taking your car seats for infants and children. And one of the things we have learned since the pandemic or with the pandemic is prevention for COVID-19. So we still track new cases and also time your vaccines if you're traveling abroad and you do need some protection. Education about respiratory illness exposures. We just heard about the preventative measures, wearing a mask to prevent spread of infection if you have an upper respiratory infection, or if others around you do have, it does help And this is in addition to hand washing or sanitizing. Next slide. So the resources for the clinician, again, there are a few things. I provided you the link to a template for rapid evaluation, what you need to get from the patient, and also some travel clinic information, because the yellow fever vaccine is provided only in certain travel clinics or the health department, and you need to schedule ahead of time so that they can acquire the vaccine specifically for you. Next. During travel, pretty much the same theme goes. Wash your hands, safe transportation, bug bites. Choose safe food and drink. Avoid animals. Excuse me. Avoid animals. Definitely use protection against sun and extreme temperatures. Next slide. After travel, depending on your exposures, if you have an illness within, say, 2 to 4 weeks after you return, it's highly likely, in addition to the common infections and illnesses that you could have from your community, you may have brought in something from your travels. And the physician assesses, again, the route, return dates, exposures, your vaccines and prophylaxis that you have taken, and also what is your risk factor for getting ill. So definitely have your patient touch base with you if these issues arise. Next slide. One of the infections outbreaks we are seeing in the US, predominantly related to international travel, along with low vaccination rates in the community, is measles. The most recent numbers as of the first week of May is about 139 patients in the US who have presented with a rash, and 82% of them are unvaccinated. So just make sure that your patients are vaccinated against measles. Is like it was mentioned initially, 1 dose protects you about 93%, and then 2 doses is almost 97 to 98% protection. So just make sure all your patients are up to date on their vaccines. And most of the children who are exposed or have disease due to exposure are children who have not been vaccinated. And I found the clinical scenario, very interesting. By the time this patient was diagnosed, a few people were exposed because of inappropriate personal protective equipment. One of the ways we can mitigate that is asking about international travel and immunization status. Increases your risk for measles. And also understanding what are the CDC recommendations for outbreaks. Next. So as a healthcare provider, a few things you should be on alert since we are now in an outbreak time. Look for patients with febrile rash, illness and symptoms consistent with measles, the 3 C's, cough, coryza, or conjunctivitis, and an exposure or having recently traveled abroad to countries with ongoing measles outbreak. And you will see the travel health notices on the CDC website, travel website, which gives you what's the rate of spread or transmission in those countries. Infected people are contagious from 4 days before the rash starts and through 4 days after the rash presents itself. Next slide. And these are your references. Any questions?
Yeah, we have a couple questions for you. So one is, how costly are travel vaccines, and is there any financial assistance available to help folks get those before they travel?
So the health department usually does it without cost. Sometimes they do ask for a small amount. Few years ago, the vaccines like yellow fever was anywhere between, just the vaccine alone, not the administration cost, was anywhere between $75 to $150. I think if you're going to areas where that yellow fever is prevalent, this would be a really good vaccine to take. And once you get the vaccine, you're immune for life. So I think it's worth spending those dollars if to prevent that. Yeah.
Sure. And then another question, during the pandemic, we would hear stories about folks being isolated once they reached a new country and things like that. Are there any checks when you enter a country that you've received your vaccines? And if so, are there any repercussions if you haven't? Do they quarantine you? Do they isolate you? Do they vaccinate you upon arrival? I'm just curious if there are any stories about that.
So two areas, I mean, at least one area you have to be very careful about is entering and exiting a country that has yellow fever. So there are certain countries which will not allow you to re-enter if you have gone to an area where yellow fever is endemic and you've not had the vaccine. Because the mosquitoes in the two countries, in one country, the mosquitoes have yellow fever virus, the other country doesn't have. So they don't want their mosquito population to get it. And in addition, you don't want to, which will lead to spread of the disease in the community. So there are very strict protocols there. And if your passport says, hey, I traveled to Africa, the yellow fever belt, and then within a week, you're re-entering a place like India or another tropical country, they will definitely ask you for that vaccine record. If not, they will give you the vaccine at the port of entry. So yellow fever, it's very strict in certain countries, whereas COVID-19 used to be, but not so much anymore. It is ideal to carry your vaccine records with you because it has been a very fluid situation, but has stabilized over time. But as of now, I do not believe any country requires you to have the COVID-19 vaccine. Having said that, I would say before you travel, just go to the travel website, the CDC, put in your location, and it will tell you what are the absolute requirements for that location.
That's very helpful. Thank you. All right, we will move on to our final speaker. We have Jessica Webker with us. Go ahead and introduce yourself, Jessica.
Thank you. Hi, good afternoon, everybody. My name is Jessica Webker, and I am a regional school nurse consultant with the Ohio Department of Health School Nursing Program. And I'm happy to be here today and present to you this portion of the infection control and prevention topic. And I actually will be discussing the ways the school-based healthcare provider and the primary care provider can collaborate on best practices. My personal background in nursing includes several years of public health experience, both at the local and the state level, as well as experience working in the K-12 school setting. I have been involved in communicable disease management and immunization coordination at the county level, and I'm currently completing my master's degree in nursing through Cedarville University with a family nurse practitioner focus. Next slide. So as I mentioned, I will be talking to you about those collaboration practices between the PCP and the school health provider. Next slide. So before we discuss collaboration approaches, I think it's appropriate to first define the school-based health provider. So who exactly is this individual? Although school-based health providers in Ohio can take several different forms from nurses up to physicians, the most common that we see in most Ohio schools is going to be the school nurse. And since this is my personal level of experience, I'm going to refer to the school-based health provider as the school nurse for the remainder of the portion of this presentation. A lot of questions we get is, what do school nurses do? Despite popular beliefs, school nurses are not just there to put on Band-Aids and hand out ice packs to students. In fact, according to the National Association of School Nurses, the professional school nurse is considered a leader who bridges healthcare and education, provides care coordination, advocates for quality, student-centered care, and collaborates to design systems that allow individuals and communities to develop to their full potential. In other words, the school nurse plays an integral part in keeping children healthy and in school learning, and that's not a small feat. On this slide, you will see that I've listed some of the various roles the school nurse plays in the school setting, which not only include acute care of the ill or injured student, but also includes tasks such as care management of the student with special health needs, and of course, promotion of wellness and disease prevention. Next slide. So next, let's identify some of the infection control challenges that schools and the school nurse face in their day-to-day practice. So first, let's talk about congregate settings. We know that schools are, in fact, considered a type of congregate setting and that children spend a majority of their day learning, eating, and playing in close proximity of one another. This in and of itself can play a significant part in the spread of infection, especially illness that's spread through airborne and respiratory particulate. We learned during the COVID-19 pandemic that proper spacing really can make a difference in reducing the spread of certain illness. However, this setup is rarely achievable long-term in the school building and creates a unique challenge in controlling infection control and spread in that school setting. Second, a lack of personal boundaries and poor hygiene practices is something that we see often. We know that children are not always the best at respecting others' personal space and tend to be in each other's spaces often, especially when they're small. Additionally, children and adolescents are not always the best at good hygiene practices such as washing their hands after using the restroom, covering their coughs or sneezes, and they even tend to eat and drink after one another. I feel like teens and athletes are especially guilty of this by sharing sports bottles and so forth. Another challenge are students who come to school ill or infectious. Sadly, we find that parents don't always keep their children home when they are ill. This happens when there's a lack of childcare, maybe there's an inability of the parent to stay home or missed work, or there may be other challenges we're not always aware of. Sadly, any school nurse will tell you that they have witnessed students come to their clinics just before lunchtime with a raging fever, only to have that student tell them that they woke up sick that morning, but the parent gave them medicine and sent them to school anyway. So as you can imagine, that sick student has now exposed their entire classroom all morning. And this is not an unusual experience, even when school policy states that they should have stayed home. Another challenge schools face is resistance to masking during respiratory illness outbreaks. Even in situations where masking would be appropriate for students or staff, by and large, we see a growing level of resistance to this practice. And so this also may create a challenge in controlling the spread of infection, particularly in that vulnerable and immunocompromised individuals during respiratory illness season. In a similar vein, we know that funding can also be a challenge for many schools when it comes to school clinics. So for school nurses to have access to appropriate PPE, as we discussed earlier in this presentation, that can sometimes be a barrier in and of itself. Yet another large issue schools face in infection control is suboptimal immunization rates, which we talked about earlier. While certain immunizations are required for K through 12 school attendance in Ohio, parents are permitted by law to exempt their child from those immunizations for philosophical reasons. Additionally, since the COVID-19 pandemic, we've seen increased levels of vaccine hesitancy for all immunizations, which has lowered the overall vaccination rates in Ohio schools. And sadly, we know that those lower vaccination rates, the higher the probability of a communicable disease outbreak we're going to see. Finally, the physical space and setup of the school clinic can pose a challenge. School nurse clinics see children of all ages, some healthy, some ill. Many clinics are quite small and rarely create an appropriate environment where sick children can be adequately spaced or isolated from other students who may not be ill. Additionally, school clinics may not have the option of that pre-visit triage or an ability to make appointments. So often, the school nurse has no idea what's going to be walking into her clinic door and has little to no time to prepare. So as you can imagine, this also can create a barrier in that protection against the spread of disease. Next slide. So the school nurse has several approaches when it comes to infection control within her school. First, we provide health education to students as well as to staff and even the parents and guardians of students, providing various kinds of health education on hand washing, covering coughs and sneezes, and avoiding the sharing of eating or drinking utensils, as well as promoting healthy eating and physical exercise, can help children to learn more about the importance of the development of these healthy habits. The school nurse also monitors the health status of the district. Ask any school nurse and they can tell you exactly what seems to be going around and in what grades or in what classrooms. It's through this diligent awareness that the school nurse can plan for and prevent further spread. Another important part of the school nurse's role is improving vaccination rates. Not only do they often monitor the immunization status of all the students, they can continuously provide education to parents and guardians on the importance of these immunizations and provide or often facilitate finding resources for them on where to get those vaccines. Particularly during cold and flu season, the school nurse is typically promoting flu vaccines as a primary prevention strategy as well. Regular communication with parents and guardians is a great outreach for the school nurse and is used often. This helps build trust between the family and the school and increases awareness of the health challenges that may be occurring at that time. In this communication, the school nurse can continue to reinforce the importance of staying vigilant of symptoms of illness and when to keep children home. And finally, school nurses partner with other school staff to help fight the spread of illness. Anywhere from working with the janitorial staff to target appropriate cleaning practices during certain outbreaks, to educating teachers and administration on how best to approach a rapidly spreading illness in the building. Initiating this team approach can help make infection control measures more successful. Next slide. So when we consider best practice collaboration approaches between the school health provider, the school nurse, and the primary care provider for infection control, there are three main areas that are identified. First and foremost, communication and partnership. Good communication between providers really is a key concept. It is crucial to recognize the school nurse as a partner in the care of school-age children and to seek to preserve continuity of care through appropriate communication. One common barrier the school nurse often faces is the inability to have open communication with a primary care provider due to fears of HIPAA violation. However, it's important to note that HIPAA allows for communication with the school health provider without the need for written permission. In fact, the U.S. Department of Health and Human Services states, the HIPAA privacy rule allows covered health providers to disclose PHI about students to school nurses, physicians, or other healthcare providers for treatment purposes without the authorization of the student or the student's parent. For example, a student's primary care physician may discuss the student's medication and other healthcare needs with the school nurse, who will administer that student's medication and provide care to that student while that student is in school. So having that knowledge, the primary care provider can feel more confident in their ability to communicate openly with the school nurse, thus opening the door for future collaborations of care. The next approach would be centered around communicable and infectious disease management. Ohio schools often follow the Ohio Department of Health Communicable Disease Chart guidance when it comes to managing communicable and infectious diseases in the school setting. This guidance may differ at times from the guidance the primary care provider may provide, creating some confusion for parents about when their child can and should return to school. One way the primary care provider can help with this is to review the most current and up-to-date public health guidance on infectious diseases with parents and families when they're in the office, so there's less confusion. And also by encouraging them to reach out to their school nurse for further information on the school policy. Another really important way the primary care provider can increase best practice collaboration is to have conversations with parents regarding school attendance. This conversation can sometimes involve the importance of keeping ill children home when needed, but it may also involve encouraging parents to send children back to school when they are well. As I mentioned earlier, some parents want their kids in school, sick or not, so having their trusted primary care provider reinforcing the importance of remaining at home while ill and infectious is helpful in reducing the spread of disease. And finally, providing Return to school notes for children is very helpful in that communication piece. It assists in excusing student absences, but it also communicates any restriction or ongoing guidance for the student as they return. So, for example, if a child's been cleared to return to school because they're no longer infectious, but they need to be excluded from gym class for a week, this should be put in writing and communicated to the school nurse so that that provision can be made. Specificity is encouraged. Finally, school immunizations are another important collaboration topic. We've heard a lot about this today, but primary care provider awareness of Ohio immunization requirements for school entry is very helpful. The Ohio Department of Health does update this requirement yearly, so encouraging the appropriate vaccinations at each visit to avoid missed opportunity is a very valuable approach. Encouraging annual flu and COVID vaccines can also be helpful in reducing the severity and the number of absences due to influenza or COVID-19 infection. Additionally, primary care provider utilization of the ImpactSys statewide immunization registry to record any administered immunizations can help improve that continuity of care and communication with school nurses. Next slide. So to wrap up, I want to leave you with one final thought. When we work together, we can make a difference in the health and well-being of our children, our families, and our communities. Thank you for your time today. And on the last slide, I have my references.
Awesome. So speaking of return to school, return to daycare, return to activities, we did have one question about what the recommendations are for return to any of those things for a child with hand, foot, and mouth. And we could have anyone from our panel answer.
So I would be happy to hear what others have to say. I would say from a school standpoint, again, kind of looking at that Ohio Department of Health communicable disease chart, at this point, there's really no exclusion recommended for children with hand, foot, and mouth unless they are acutely ill with, say, a fever or something of the sort where they should not be in school anyway. So really I would encourage them to check their school policy. But if the child has been diagnosed, but they're not acutely ill, they're not carrying a fever, and there's really no other reason to keep them away, they can return to school at any time.
Thank you. Well, we don't have any additional questions in the chat. And I think we are already over by 2 minutes. So I wanted to thank you all for your participation today. We had a chance to hear from our experts across the state about infection prevention and control in our primary care and school settings. On the next slide, I think you'll find your links to claim CME and CNE credits. So thank you all again for attending today. Thank you to our speakers for sharing their insights and experience. Have a wonderful day.